Hi, it's Dr. Centeno, and thanks so much for joining me this nice Sunday morning. Today, we're going to talk about CCI Rehab. And about a year ago, could be 2 years ago, I created the CCI Rehab program video series. And a lot of thought went into that, trying to figure out how to structure rehab, especially weaving all the different components that I felt were important and that patients were participating in. That was good. But one of the things I noticed was that it was difficult for patients to kind of fully understand all the concepts, or at least how to turn it into a practical program. So this last week, as yet another patient sort of expressed frustration about what they should be doing, when they should be doing it, etc. I said, okay, I have to sit down and put all of this into a single document, let's say a workbook that someone can use and follow along with, so that it has a little bit more structure. So that's what we're going to talk about today, is that CCI Rehab program and how the parts and pieces come together through using this workbook. Now, I don't care if I ever see you as a patient. I've tried to put this together in a logical way. Having said that, if you're seeing another doctor or a doctor outside of Centeno-Schultz, you need to talk to that doctor to make sure that they're okay with this rehab program. And you'll also want to talk to a physical therapist. If you're seeing a physical therapist, show them the workbook, have them watch the videos so they get an idea of what it is we're trying to accomplish here. So again, if you're just joining us now, really the goal here was trying to put together a workbook to put more structure behind the CCI Rehab videos that I created 1 or 2 years ago. And that was because I often saw that patients were frustrated in trying to understand it all and synthesize it into a day-to-day program that they could use. So again, this last week, I took some time, put together this CCI Rehab Workbook so that we could add structure to that program. Now, for my patients, I am going to require that they use this workbook, right? Because there's medical care related to CCI. In my case, that's the PICL procedure. I only do the PICL procedure because I'm only in the office 2 days a week now. But on the other side is rehab. And if the patient's not participating in rehab, then in my opinion, they're more likely to fail treatment. So that's why I want my patients to use this workbook. So that's what we're going to talk about today. And at the same time, if you can do me a favor, if you are either on YouTube or on Facebook and you want to ask a question, just go ahead and pop that question into the comments and I'll see it here, and then I'll answer that question in the order it was received. Now, since it's in the order it was received, realize that if you submit your questions later on, then they're less likely to get answered, specifically because I usually get more questions than I can answer. Also, do me a favor, give me a like, share, comment, subscribe. You're already commenting if you're asking questions, simply because that's how patients or other patients, other CCI patients, find this kind of content. So let's get started without much further ado. This is the Rehab Workbook. You can find a copy of it at the Reddit sub. So if you go to the Reddit sub RPICL and just look up this Rehab Workbook or search that will come up and you can download it and use it. Again, I don't have to be your doctor, but do discuss it with the doctor that you're seeing so that the doctor understands what it is you're doing, and that doctor can do an independent check to make sure this is appropriate for you. So this is the CCI workbook here. And the first concept in this rehab program is very, very simple. I told this to patients hundreds of times since I came up with the CCI Rehab videos, and that is the core rule is thread the needle. So what do I mean by that? That means that we need activity in order to get stronger. And half of instability is strength and muscles, and half of instability is ligaments. So I need my patients to thread that needle between activities that they can tolerate and getting flared up so that they are constantly pushing it a bit, but not so much that they're living in a constantly flared up state. So you have to thread that needle between the two extremes, between getting some activity so that you can get stronger, but not so much that you're living in this constant flare up state, because if you are, then that's a net negative. So that's the thread the needle concept. And this whole thing goes into what that is, what that isn't, to try to help you to thread the needle. And then this goes into all the videos that are part of this workbook. So all of those links are there for you if you want to watch the videos as well. I like video. I'm kind of a video sort of visual learner, but maybe you're not. So as far as the first part of the workbook is that thread the needle part. And this is just an activity tolerance log. Now, I've seen patients do this on their own, right? I've seen patients keep spreadsheets like this where they log their activities that they can tolerate. And so I kind of incorporated that in this workbook because I think that's a great idea. Why is it a great idea? Because it's very hard looking back over several months to see exactly where you were and exactly what was pissing things off 3 months ago, 6 months ago, a year ago. So this gives you that sense, right? It basically says date, activity, task, the dose or the level tried. So what does that mean for walking? It might be I walked for 5 minutes, or I walked for 10 minutes, or I walked around the block once, or I walked around the block 3 times, whatever that is. Then it gets into the symptoms during that, and then the symptoms during recovery, and how much that caused you a flare-up. And then a decision. Are you going to stay at that activity level, or are you going to fall back? So again, this is critical for gauging your activity and threading the needle between those extremes of getting activity so you can gain muscle and get stronger, but not so much so that you're pushing yourself into a permanent flare-up. So this is really doing what I saw patients do, right? I had a bunch of smart patients who were tracking all of their activities on a spreadsheet, and I think that's a great idea, and that's the first part of this rehab program and this workbook. And then part 2 of the workbook gets into the rehab targets, right? What is it that we're trying to fix here? Well, we're trying to fix instability, and that's got a ligament component and a muscular component. So it talks about the different types of activities that you might want to consider there. Obviously, when it comes to ligament components, you can do things like getting a cervical collar, but that's going to be a two-edged sword because that can impact the muscular stability. And try things like AO chiropractic, NUCA, orthospinology, Blair, etc. On the muscular instability side, you can work on the low-level strengthening exercises and move up. Then we get into symptomatic structures, and then proprioception or position sense, curve, and posture. So two things or a couple things that are brought in right here. One is this towel test, and that helps you decide whether you're ready for curve restoration. Curve restoration simply means getting the normal curve back in your neck to take pressure off the top of the neck. And to do that, you take a towel, you roll it up, you try to get to a moderate thickness, you lie face up on it on a firm surface, and you put it in the middle of your neck to try to improve that curve. Now, if you can tolerate that and that feels good, you're probably ready for curve restoration therapy. If you can't, then you're probably not ready. Here it talks about posture and prehab and rehab for the PICL. So that's introducing the postural program that we use. And Todd Ball, Todd works with a lot of our patients who want to do prehab, meaning try to set things up for the best possible outcome prior to the procedure, and rehab to try to get stronger after the procedure. And that's a very posturally based program. So that satisfies this part here. The towel test part gets to curve restoration there. And then the laser exercises are more proprioceptive, but it introduces those laser exercises here so that you can start to do those exercises, and that's going to be proprioception or position sense. Then another core component, which is very different than other rehab programs of a CCI rehab program, is the starting point of CCI patients is vastly different from one patient to another. So one patient might be able to do light workouts and they live sort of in a functional box, but you would look at them and say that they're relatively functional. However, they don't do 6 things that they used to enjoy doing. And on the other end of that spectrum are patients that are bedbound, meaning people that can't get out of bed. So you have to have a rehab program that allows people to enter at all those different levels. And that's a key component to this program. So we have here bedbound, very limited, mostly functional. And then it talks about the best first steps there. Now, there's a video that goes with this as well. But the concept here is that if you're bedbound, you're starting at a very different place than if you're functional. And then there's a workbook exercise there where you're matching rehab to your functional level. So you get to pick that. And then it talks about moving to the next is rehab workbook component. And then this one talks about how to progress each one of those rehab areas that we were talking about. So for instance, a big component for some of my patients, but not nearly all of them, would be weaning out of a collar, some pretty simple stuff. Or for others would be how do you use upper cervical chiropractic to help you heal? Or for pretty much all of the patients I see, muscular instability and strengthening. Another big component is symptomatic structures. What's holding you back? Now, this is a hard one for patients to understand. And that is that in many of my patients, there are things that are holding them back. Now, the obvious one for the patients I treat with PICL is craniocervical instability. But for other patients, it would be a large disc bulge pressing on the spinal cord at C5-6, i.e. they have both of those things. So they've got a control for both of those. Or there might be injured joints or irritated nerves. So it's understanding what those symptomatic structures are and whether or not they need to be treated with interventional orthobiologics to help you get to that next rehab step. Then we get into all the position sense stuff, proprioception, neck, eyes, balance, and then curve correction, as I've mentioned already. And then finally, posture. And then this 5th chapter really just talks about what to do when rehab stalls, and that's really getting back into some of this symptomatic structure piece that we talked about, right? This one here. Oftentimes rehab stalls because of those symptomatic structures that aren't treated, but sometimes rehab stalls because someone's moving too quickly through the program or they're not understanding that thread the needle concept. And then we've got a lot of different workbook activities here, a collar weaning workbook so that someone can try to get out of that cervical collar. There's another workbook that gets into upper cervical chiropractic and tries to focus on that holding time. Are you increasing your holding time as things move forward in your overall rehab program? So for instance, if you start out holding for 2 days and after doing X, Y, and Z, you can now hold for 2 weeks, that's important and that should be tracked. And then there's another component that looks at muscular instability and strengthening. And it walks you through all the different levels of strengthening here that you want to get through. And this is important for me, right? As the doctor, if I see that someone is stuck at a certain level here, let's say they're stuck at the 3rd level, deep neck flexor activation, and they can't get past that, that's a critical thing for me to know, because it means we're not going to be able to get that person fully back to normal if they can't get past that spot in their rehab program. And then there's a symptomatic structures tracking table so that you can keep track of those structures. You should know your body well enough in CCI to know that you have a 0-1 facet joint problem, or that your vagus nerve is an issue for you, or your greater occipital nerve on the left is an issue for you. And this helps you track through all of those different parts and pieces that we would look at. So again, very important stuff here. Or that your left shoulder is chronically unstable, and that's potentially holding you back from getting where you want to be functionally. And then there's also a position sense or proprioception workbook here that goes through all the different levels of position sense or proprioception that you want to get to. Again, same thing here. As a doctor, if I see that you're stuck at the neck exercises in level 2 and you can't get beyond that, that's an important piece of information for me. And then goes through postural physical therapy progression. Obviously, if you're working with Todd Ball, this is covered. But if you're just doing this on your own, this is a good way to look at this postural progression. You may get stuck in here, right? And if you do, that's another important thing for me to know as your doctor and for you to know as the patient. So that's the workbook. Again, the goal here was to try to formalize some of that program so that patients had some things that they could do and some things they could track, but also critically important for me as the doctor to see if someone's getting stuck in that program. Because if they're getting stuck in that program, they need more than just rehab. Or maybe they need to switch horses, right? Maybe they're focusing too much on curb restoration and it's not going to be achievable for them, but they could make progress in position sense or proprioception and on postural things. Okay, so that's on the Reddit sub. I'll try to see if I can put the link to this as well, so that in the show notes here or the description, we've got a link to download that workbook. That would make sense. So let's get to some questions here. Again, you can ask questions about this or really anything else. So let me get out of this here. And then we'll go to sorry guys, they've switched this stuff around on me. Okay. That's the problem. Okay, we got it there. So first, just a comment, Vivek, Level workbook, yes. Thank you, Vivek. It's going to help me as much as it's going to help you guys as well. Good morning, Dr. C. 6 days post PICL number 1. Recovery went smooth and easy. Great to see you, Stephen. Thanks so much for letting me know. Stephen, I feel as if I had some immediate relief from PICL. Can this be from temporary stability from inflammation? Yeah, that's usually related to what we call the donut hole, or that donut hole concept. So basically within the first week to 2 weeks, there's acute inflammation, and that acute inflammation, even though you may have some pain related to the procedure, is causing more stability in those ligaments. And eventually that goes away. Now, it can also be because you really had a big symptom generator in some of the other structures that were treated, like the upper neck facet joints, like the nerves, and those are also doing better, in which case it won't be so much of a donut hole. KCN for SI joint unstable patients that don't respond to regen treatments like Prolo and PRP. Would you consider fusion? If so, have you seen the intra-articular bone allografts that have little downtime? Yeah, so I don't think fusion is a good option at all. Unless someone has not responded to appropriate regen med treatment. So appropriate regen med treatment would be, you could start with something like prolotherapy, but that takes a lot of visits, right? For the average female patient, in my experience, that's 6 to 8 visits of prolotherapy. Many times you also have to inject the symphysis pubis up front to get that to work because it's the whole pelvic ring that's unstable. Then you could go to PRP and probably do half those number of visits, or bone marrow concentrate and do half those number of visits again. So if someone has failed, let's say prolotherapy and bone marrow concentrate, and it's pretty clear they've got SI joint instability, then you can certainly consider a fusion, but a fusion is just a crappy option. It's a crappy option because the SI joint is built to move. So if we fuse it in any substantial way, we're going to get adjacent segment disease, meaning the hip's going to start to wear out on that same side, or L5S1 is going to start to wear out on that same side, because the function of the SI joint is a shock absorber to take energy from the legs and lower body and move it up through the torso. Stephen, can hydrodissections create immediate relief? Yeah, so that's one of the things I was just talking about, Stephen, is it's possible that one of those targeted treatments to a symptomatic study, or sorry, to a symptomatic structure, like let's say a greater occipital nerve, may be providing relief. Greg, thank you for addressing this and adding structure and ease of use to this rehab program. Well, thanks, Greg. Yeah, I could see that some patients were struggling, so I wanted to try to put something out there. Vero, any tips on figuring out by myself whether my suboccipital corner pain is coming from the C01 facet nerves or suboccipital muscles? Well, when it comes to the facet joints, there are facet joint referral patterns that you could easily look up. They're different. When it comes to pain that's right across the base of the skull here, that's usually the C12 facet, for example, versus pain at the back of the head, which could be either the 01 or the 23 facet. The 23 facet can be associated with dizziness, so that might push you more in that direction. As far as the nerves go, you've got greater occipital nerve, which again has a certain distribution, lesser occipital nerve, which has another distribution, so that might help there. And usually you can make that worse by pressing back here, or better by gating it. So pressure back in here usually makes nerve issues better or worse. And then the suboccipital muscles themselves could be exquisitely tender, which might make you think that they could play a role. So probably the best I can do there. OSIC, losing memories, identity, and having brain fog is scary. I'm still able to work, go to the gym, and survive everyday life. Is it possible to regain my personality that I had before neck problems? I don't know your clinical history and your specifics, so really hard to answer a question like that. I can tell you that if the brain fog is related to craniocervical instability due to internal ligament issues, that we've had quite a few PICL patients where the brain fog has gotten dramatically better or gone away. So that's probably the best I can tell you. Casey, do you have an opinion on the GLP-1 meds, whether they help or hinder the regen process? They probably help because they help to control the #1 cause of disease, certainly in developed countries. And I was going to just say the US, but Europe is just as bad now. Guys, when I first started going to Europe 25, 30 years ago, everyone in Europe was thin. No longer the case. Europe has the same obesity problem that the US has now. So GLP-1 meds tame blood sugar instability, which is sort of the #1 cause of disease in the developed world. So yeah, they would be great for the regen process. Now they do need to be stopped a week before you have anesthesia. Otherwise you will get stuff coming up during the procedure because they do slow the gut down. But I think that they're a big net positive for any type of regen med process or healing. Stephen, I think I already explained what the honeymoon process is, but basically what it means is that there is swelling in the ligament that causes ligament tightness, so someone feels quite a bit better. Then that acute swelling goes away, so the tightness of the ligament goes away, instability kicks up. That instability is associated with more symptoms or return of symptoms. And then eventually you get remodeling in the joint, and that remodeling, remodeling in the ligament, and that remodeling leads to a tighter, better ligament connection, so the symptoms abate again. Can any type of infection cause CCI? Not that we are aware of right now in 2026. That doesn't mean that information might not come available on that issue, but we don't have good solid data that infections lead to craniocervical instability, at least the kind that we're talking about here in 26. Stephen, I've had a water in the ear sensation since PICL1, thought on what that can be. It's possible that that could be related to the treatment of the lesser occipital nerve or the superficial cervical plexus. That's possible. Casey, do you have any reference available as to which rheumatologic meds need to be held and for how long before and after regen treatments? Yeah, so most rheumatology meds are very strong anti-inflammatories, and they're really, for lack of a better term, powerful immunosuppressants. What happens when you take a powerful immunosuppressant is that it blocks the acute inflammatory process, and inflammation is necessary for healing. If you're going to be getting an EPICL procedure, there's a very long sheet of medications that we give you that need to be stopped, and those would be on that list. HRS, absolutely, for sure. I love that we've reached the point where we just decided to start poisoning fats to death. Should have started with the, oh God. Okay, that person's gone. Julie, hi, Dr. C. At what point in rehab is it appropriate to start doing rehab on hands and knees? For example, cat-cow, alt-arm leg raises. This has put too much stress on the healing ligaments 8 weeks after my 3rd PICL. That's going to follow that workbook that I just went over. So I encourage you, Julie, to get that workbook. And if you're working with Todd Ball, that'd probably be a question for Todd, who probably knows more about where you are physically at this point. But for most patients, it would follow, again, that thread the needle. So you might want to try cat-cow a couple times, see if that aggravates your neck. Maybe you can do 5. And then if you do 6 or 7, it aggravates your neck and your symptoms. So you start with 5 and you stay at 5 until you've mastered it. And then you try 7 again and see if it irritates your symptoms. If it doesn't, you stay at 7, etc. Casein, a rheumatologist told me regen treatments still work on a 5 milligram prednisone dose if getting off of it would be intolerable. We don't have any peer-reviewed information about that at all, so I think your rheumatologist just made that one up. 5 milligrams of prednisone is a humongous dose. We need to understand that and this is something that the rheumatologists have a hard time understanding, the physiologic dose of corticosteroids in the body is in the nanogram range, or a billionth of a gram. So a milligram dose is 1,000,000 times too much. So for example, if I take mesenchymal stem cells, which are the cells that we're relying on in many of these procedures to help heal, and I were to put even 1 milligram of corticosteroid in that mesenchymal stem cell culture, and remember, we're not some fly-by-night clinic. We've got a full research lab where we can grow cells in culture. That kills all the cells quite dead very, very quickly. Even if I put in 100 micrograms, it's still going to kill the cells. Now, if I put in 100 nanograms, now we're not going to kill the cells. So again, I would suspect that your rheumatologist hasn't really had any formal training in regenerative medicine at all, and is sort of relying on a big telephone game here, not really understanding the literature that has been put together by pioneers like myself in regenerative medicine who have done those experiments to try to see what the effects of corticosteroids are on those cells. Vera, what if we try to do rehab exercises, but we don't progress or get stronger or just flare it up? Again, that's talked about in that workbook, right? What that means is that there's something blocking you there, and then you need to get treated. And what I mean by treated is if you've got craniocervical instability, then that needs to get treated, whether it's through posterior injections if you have a type 3A, or PICL if you have the other types, or a fusion. You're going to need to have something that gets treated. Or, as I said before, change horses. So it might be that postural stuff flares you up because your posture is already so screwed up from being so screwed up for so long that the bones have changed shape, so that you're going to focus on something else, or you'll have to modify that postural program, for example. Bobblehead, neck pain on the right side, feel like being pulled, like my head turns to the left, unbalanced feeling, fatigue since high velocity neck adjustment in March 2025. Since then, so no question in there that I can see, but I don't do online diagnoses. That wouldn't be appropriate as a doctor. JS, how long after are patients booked out for the PICL after the telemed meeting with you? That really depends on the time of year, etc. So I don't really know the answer to that one. That one is best for staff who can give you an idea of that. But for my schedule, it's probably going to be on the order of 1 to 3 months. For Dr. Schultz or Dr. Pitz's or Dr. Merkel's schedule, it might be much, much shorter. Winter's Whisper, how can one integrate cervical decompression, whether it be a Y strap, ring dinger, or the slower the dorsal compression devices? if we're talking about craniocervical instability, any of those would be a really bad idea. A Y-strap in particular, or a ring dinger in particular. None of that's really compatible with cervical instability. Where I live, you are not allowed to use chiropractic as rehab. Don't know what that means. Chiropractic is rehab. They're kind of separate things, right? Upper cervical chiropractic, NUCA, AO, Blair, or orthospinology is what we're talking about here. And that isn't so much rehab, but it can be part of a rehab program to help someone get stronger. I've been doing AO adjustments since January 2026. I don't hold for more than a week. Is it possible that high velocity neck adjustment that I've had create instability? Now what? Yeah, AO isn't high velocity, but if you're not holding, then the thought is that you could be unstable. So you might want to get worked up for craniocervical instability in particular. Now, if you've had high velocity neck adjustments in the past, can that injure ligaments? It can. Cynthia, I just discovered that my daughter walks. She's always looking at her feet. That caused her head to be forward. And she tried to be in a more neutral position. When she attempted it, she started tipping or tripping maybe. What type of rehab can work to remedy this? Yeah, I think you're going to have to find a really high-level physical therapist. Now, you might want to start with Todd Ball, who can do some online stuff, or find a local IPA physical therapist, but either or would be probably a good start. Listen, kids are used to doing this all day, which is absolutely, positively, ridiculously awful for your spine. I suspect that could be part of it. Also realize that many EDS or hypermobile kids never really develop normal muscle activation patterns. So it could also be related to that. Lori, please say again where this workbook is. It would be nice to get one physically after a treatment. If you get treated in our clinic, Lori, we will give you this to download, but you can also get it by going to the Reddit sub, RPICL. So if you just go to reddit.com and look for r/PICL, you can get it on that Reddit sub. Nicole, advice from my daughter who starts in college in August about how to rehab on her own, where to start. Yeah, Nicole, so I would recommend getting a copy of this workbook. You can just, if you have my email, just reach out to me. I'll send you the URL for it. And this would be a good place to start. Now, if you're really confused about where to start still after looking at the workbook, then I would recommend starting with Todd Ball, who does online physical therapy. We may have talked about that in the office. Pink Fur, can a disc bulge in the cervical spine benefit from PRP? In general, yes, but a lot of it depends on A, where you're injecting the PRP, and B, what it is you're trying to accomplish. So for example, if you have a disc bulge along with degenerative instability that is causing a nerve to get irritated, then you can use PRP, but you have to inject around the nerve. And that's a X-ray guided fluoroscopy contrast procedure, which is more advanced than just doing neck prolotherapy. Now you can add in neck ligament injections with that. So the PRP is important, but also where the PRP goes and how it's specifically put there and why is also critically important. JS, are there people with CCI who have had success doing other therapies that helped or corrected their CCI at C1, C2 before considering PICL? JS, that's a harder one for me to answer because I tend to see the patients where that didn't work. So that's probably a better one to try to source on various social media, Reddit, the Facebook group, etc., to try to find those people, because remember, I'm only seeing the ones that would fail something like that. Beast Gamer, what if laying flat ground and extension makes it bad? What ligament could that be? Can't answer that question. Too vague and not enough information for me to answer that. I am not so good at English, have had stroke, PTSD, 7 car accidents. So Ingun, I apologize, I'm not fully understanding the question there. Maybe give that one another shot. Greg, almost 10 weeks out from EPICL number 1, I've noticed tinnitus, sinus, and TMJ issues have heightened. Many other symptoms wax and wane is typical at this somewhat early stage. Yeah, Greg, we don't really look at PICL rehab till month 3. So that would be about 12 weeks out. And then there are some patients where they need to wait until month 4 or 5, for example, for us to really make that determination. So that's the best I can tell you there. Is still a little bit early there. Stephen, what's the name of the Reddit sub? R-PICL, so r/PICL. If you just go to Reddit and type in PICL, you're looking for the PICL sub. There's a couple craniocervical instability subs out there, but this one is PICL sub. JS, piggyback on pink fur. How can PRP treat a disc bulge if it's compressing the spinal cord? Does PRP correct the disc or the muscles and ligaments? Yeah, so much of that's going to depend on the amount of compression of the spinal cord. For most patients that have disc bulges irritating the spinal cord or a nerve, the PRP works well. How does it work? It reduces degenerative instability, and it's the disc bulge plus the instability that are causing the symptoms. So if you get rid of the instability, that helps a lot. It also can help treat the nerve, meaning provide growth factors to the nerve. So that's how it works. Now, are there degrees of compression where it's probably not going to work? Yes, there are, for sure. Lindsay from Utah, what could help someone with CCI to be held back from rehabbing because of sensitivity to weather changes, vertigo, tight shoulders, pressure on the brain? Every day is different with symptoms. Yeah, so one of the things to think about if weather changes are causing CCI type symptoms is the upper neck facet joints. Facet joints kind of act like little pressure sensors. So for example, when the air pressure goes down, they tend to swell a little bit. And if it's one of the upper neck joints that's having a problem, those can cause CCI type symptoms. So that's something to think about there. Stephen, any recommendations for where to get a DMX in Canada? I found one clinic in Langley, British Columbia, or would you prefer me to visit your clinic in Colorado? Stephen, either or works. If you get one done in Canada, then we can look at it and give you a better idea of what kind of treatment you might need. If you get one done in Colorado, obviously we can't have that discussion until you get out here, but either one is fine. JS, when is it time for fusion on a disc bulge? Well, probably 90% of disc bulges that are symptomatic don't need fusion, so that's the good news. But when the disc bulge is bigger and or we can't effectively treat it using conservative measures, and that person is still functionally disabled. DC suburb. What is the hierarchy of important prehab and rehab interventions for CCI? Are all approaches equally important to implement, or is there a way to prioritize and sequence it? For that answer, I think the best thing to do is to review that workbook. JS, what is hydrodissection of the vagus nerve and what's the purpose? Sure, if the vagus nerve is having problems like any other nerve, it can be treated. Problems related to vagus nerve could include problems with your blood pressure, POTS-like issues, problems with tachycardia, rapid heart rate, gastroparesis, those sorts of things. And so the purpose of treating it in those patients is to try to help reduce those symptoms. Now, normally the vagus nerve is getting irritated at C1, C2, so you also have to treat the instability at C1, C2. Do you recommend that patients do myofascial massage and trigger point massage after a PICL procedure? Again, using that thread the needle approach only if that was well tolerated before the procedure. And so, for example, someone comes to me and they use myofascial release, and it dramatically helps them for a week. Every time then I would say definitely continue that after the procedure. HRS, how often can you aspirate from bone marrow before causing damage that causes long-term pain or significant reduction in stem cells? Yeah, we did that study. So if you are anything but a perimenopausal female, there doesn't seem to be any impact on reduction in stem cells. If, however, you are a perimenopausal female, then you're going to want to either put more time between the bone marrow aspirations because you can reduce the stem cell number on the draw, or go to a different type of technique. So the first bone marrow aspiration technique, for example, might be perpendicular to the pelvic wing, whereas the second one might be longitudinally down the pelvic wing. Casey, how do you know if a disc bulge is pathologic or just a result of high muscle tension from another dysfunctional joint? Not sure of the question there, but again, I think as I mentioned before, disc bulges can cause problems. You determine if they're causing problems based on a hands-on physical exam and looking at the imaging, and then you obviously try to treat that level to see if the symptoms go away. If the symptoms don't go away, regardless of that kind of treatment and physical therapy, and the person remains disabled, then that person may need surgery there. John, hi, Dr. Centeno, can C1, C2 relationship loss, not sure what that means, and eye movement be the sole cause of dizziness, even with things like cervical medullary syndrome? John, I'm not quite sure what that means in context. A lot of terms there that don't necessarily fit together. So the upper neck is jacked into reflexes that control eye movement. And also the upper neck is required for normal balance. So if you've got an upper neck injury, let's say at C1, C2, that can both impact eye movement and cause dizziness. All of those things having nothing at all to do with cervical medullary syndrome, meaning that's a separate set of issues. Oops, sorry about that. HRS, can you talk about the settings of the CR machines you use and the radiation dose, especially to the iliac crest aspiration? We normally don't use X-ray or fluoroscopy for a bone marrow aspiration, so that would normally be 0. Now, if we were to, then it would be on the order of several chest X-rays on average, just using that to check your placements. like if I had bad concussive fall. Yeah, I'm not quite sure in context here. Let me see if I can go back to where that all was. Yeah, I think I'm going to skip that one because, again, I think, again, you're asking for a diagnosis, and this is not the place to get a diagnosis. HRS, what is the earliest one can get reinjection of cells at injury site after aspiration with Regenix C at your Cayman site? What is the earliest one can get reinjection of cells? So when it comes to culture expanding cells, normally they're grown for as little as 14 days to as long as 21 days on average. So that's the earliest you could get reinjected. Now, realize the Cayman site doesn't treat upper cervical or craniocervical instability issues. So if that's what you're referencing, that would be a bad match there. But if you're talking about something else, then it's 2 to 3 weeks. Dr. Centeno, if someone has C1C2 facet joint dysfunction or syndrome without instability diagnosed by blocks, does PRP help more the capsules or the facet joints themselves? So the whole C1C2 facet capsular thing is kind of a little bit of a scam. And what I mean by that is that the whole facet capsule thing was started by physicians that were doing prolotherapy. They didn't really have the training in order to park anything inside the joint. So they were sort of just injecting at the back of the joint. But they had to name a structure that they were injecting, and so they just threw out facet capsules. Are they injecting the facet capsules specifically? No. Might they inject some facet capsules during the procedure? They might, but they've obviously got no idea because they're doing this blind. So I'm not quite sure what's being asked there in context, meaning if you're treating a damaged C1C2 facet, then you should get the stuff in the joint primarily, and that would be an X-ray guided, contrast confirmed, highly advanced injection, could be PRP into that joint itself. As far as injecting the facet capsules, you can certainly do that on the way out of injecting the joint. But if someone's telling you they want to inject the facet capsules, that's a little bit of a scam in and of itself, because at the end of the day, they don't really know that they're injecting the facet capsules. They're just sort of throwing that out there because it sounds good. Rico, I think. Do you utilize MSC stem cells or own autologous? Again, a little non sequitur there. So mesenchymal stem cells come from your own body and are all over your own body. And then you can also get them from a donor. The problem with using donor stem cells is they tend to get taken out by your body's immune system. So it would mostly make sense at this point to use mesenchymal stem cells from your own body so they don't get taken out by your body's immune system. Dr. Centeno, if someone has ulnar nerve moderate intraneural scarring from stretch injury, could PRP help, and will it penetrate to the inner scar part of the nerve or just the external part? Yeah, so what you're describing, if it's intraneural, that would mean that the scarring is between the nerve fascicles. So not outside the nerve, but inside the nerve. So you could put PRP around the outside of the nerve, which would help the nerve in general. Now, is it going to help the scarring inside the nerve? Probably not, but it could well help the nerve. And I'm not quite sure how to make the diagnosis of moderate intraneural scarring with any technology, whether it's ultrasound or even MRI. So that's a hard diagnosis to make at this point with accuracy. Cynthia, does the location of the bone marrow aspirate on the hip affect the stem cell count that you get in the clinic? I know there are other factors involved for stem cell count in a patient, but wondering. Yes, Cynthia, so there's two primary ways we do a bone marrow aspirate, both at the same site, the PSIS. One is going perpendicular to the pelvic wing. The other is going lengthwise into the pelvic wing. So those are the two different approaches. They can get approximately the same number of cells, just different ways. Erica, have you seen mast cell activation with CCI? Yeah, Erica, I would say about 1 in 4 to 1 in 3 of our CCI patients have mast cell activation, MCAS, etc. Casey and I keep telling patients about YouTube live presentations, as where else can you get the guy who wrote the Regen playbook, as accessible as you are. Thanks for giving us your valuable time. Thank you, Casey, and for recognizing that this is my Sunday. I do this stuff, as I always say, because I think it's important for patients to get educated. And yeah, I'm one of the grandfathers of regenerative medicine. So everyone out there that's claiming to do regenerative medicine now, learn from someone who learned 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 from us. So at the end of the day, I did some of the first regen med procedures on earth. You can just go into the peer-reviewed literature and see my stuff there. I think the only guy on earth that's been doing legit regen medicine longer than I have is Philippe Herdegau, who's now my colleague at Regenix. We're getting Philippe's last papers out. He's got another probably 4 or 5 yet to be published, some data sets that needed to get published. But so you could call Philippe the grandfather of modern orthopedic-based orthobiologics, and I guess I'm the father of modern orthobiologics at this point. So between the two of us, I don't think there's anyone on earth that's been doing this longer than we have. I suspect I have CCI and have done vestibular vision and neck PT. Neck PT helped a little. While searching for a doctor who understands CCI like you, what background should I look into for their bio? Yeah, regrettably, it's hard to find physicians that understand CCI. Now, I've lectured to probably at least 500 or so physicians through the years on CCI. So I think that there are more physicians who understand that it's a thing out there. And usually what happens is that they will suspect it clinically, and then they will maybe do a test like a digital motion x-ray, and then if something's found, they'll send that case to me for further workup and treatment. As far as trying to find a physician that really understands CCI and can do all the different procedures, that's going to be a hard one. Carol, submitted advanced by Harry Winston. How long would someone need to be in Colorado for the newest PICL procedure? I was told by someone who's had one recently that it's a shorter period of time than it used to be. Pretty similar to what it used to be. If you're domestic, then let's say 2 to 3 days. If you're international, then more like 5 to 7 days. But that's probably hasn't changed. Spinal cord stimulator paddle with laminectomy and cervical and explanted or removed, developed cervical instability, forward head and shoulders afterwards. Now shows I have an arachnoid cyst at T1. Does that contribute to the instability? We wouldn't expect an arachnoid cyst at T1 to contribute to cervical instability. E. Smith, have you ever studied peptides like BPC-157? We don't use any peptides like BPC-157 simply because there is no way to we're actually getting real peptides like BPC-157. We talked about it at one point to do a study, but there was no assay that existed for BPC-157. That's how crazy this is, meaning that if I want to, as a researcher, buy some from one of these fly-by-night companies that are selling this stuff on Facebook, the first thing I have to do is to make sure what I'm really getting is BPC 157 and what dose, right? But there is no assay, immunoassay that I can buy for BPC 157. That's how crazy this is, that patients are buying this stuff and using this stuff, because not even as a researcher, I can't even find a commercial assay that tells me what's in the vial. That's using hundreds of thousands of dollars worth of lab equipment and research time. So if I can't even determine as a researcher what's in the vial, you buy it on Facebook and injecting it or using it in your body. So that's my 2 cents on that one. Hi, Dr. C. Thanks for the shout outs today. Here's clients to schedule a consult. Thank you, Todd. Yeah, Todd's been great. Worked with our patient population, understands our patient population, and we recommend him highly. Okay, guys, so I am at 1 hour, so I'm going to start winding this up here. I know that I've got more questions to answer. As I said, kind of when we started, if you get your questions in early, I can answer them. I will be here next week at 10 a.m. again on Sunday, talking about something else and then answering questions. And thanks so much for all the great questions today. There are no bad questions. Questions are how we all learn. So thank you for taking the time to be with us here today. And have a great week. I want to make sure that everyone gets a copy of this workbook. So I will try to put the URL in the description here for this video. You can also get it by going to the Reddit sub. And just so you know what that looks like. So let me share that here. So that's what the Reddit sub looks like. It's called PICL. And if you just go to Reddit and just type in PICL, it should come up. And this is what the Reddit sub looks like. If you just scroll down a little bit, you'll get to that post, which is right here. Then you just click this link. This link will take you to the actual file here that you can download. So that's where all that stuff is. Thanks so much for watching. Have a great week, and I'll see you next week. Thank you.